So my name is Ashwin. I'm a Urology registrar in Newcastle, currently working at Sunderland Hospital, and I'll be talking about first-line hormonal therapies in prostate cancer. Broadly, some of these topics might be covered by Brabs earlier, but the outline is I'll be talking to the rationale for why use ADT, the different modalities, surgical and medical, some of the side effects associated, and what the current guidelines are for use of ADT in different stages of prostate cancer. So to start with, it's important to know that we've come a long way. Prior to the availability of ADT and our understanding of the endocrine influence of prostate cancer, outcomes for prostate cancer were extremely poor. Currently we stand at, with the use of ADT, a median failure-free survival of about 11 months and overall survival of about 42 months. Despite this, what this means is that at 2 years, up to 28% of patients would die with metastatic prostate cancer. So there's still some way to go, and trials such as that of the Stampede trial have provided some more information on how we can work and build upon ADT to improve outcomes. Though ADT remains the foundation of treatment for advanced prostate cancer. And it's really driven by the work of these two people who got awarded Nobel Prizes for their work on prostate cancer. And Charles Huggins, which Prabs talked about earlier, really elucidated the hormone dependence of prostate cancer with some very elegant experiments. And later on, Andrew Shalley identified GnRH and developed synthetic GnRH agonists, which we now use for medical castration for prostate cancer. So the experiments done by Huggins and Hodges were particularly interesting, though they had few patients in their seminal paper. They performed orchidectomies in some of these patients, and to assess the response to these treatments they used alkaline phosphatase, which was a marker of prostate epithelium in the primary tumour, and alkaline phosphatase, which was a marker of osteoblastic function due to bone metastases. So the orchidectomy led to a reduction in these markers, which suggested tumor regression or tumor suppression, and low acid phosphatase demonstrated this in a biochemical level. On the other hand, if patients were given testosterone, it led to an increase in acid phosphatase, suggesting tumor progression. And these sort of experiments would perhaps now be unethical to give patients testosterone, but they provide the very seminal information of cause and effect of the role of testosterone in prostate cancer, and the use of orchidectomy to suppress prostate cancer progression. So, broadly speaking, and in a very simplified sense, the androgen dependence of prostate cancer cells depends upon whether the cells are benign or hormone-dependent malignant cells. So benign cells and prostate cancer cells would both grow and proliferate and increase in size in the presence of androgens, but when androgens are absent, benign cells would shrivel down, and this is why you'd get some response to things like 5-alpha reductase, such as using finasteride for treatment of BPH. And on the other hand, cancer cells would die as a response to the absence of androgens, and this is really setting out the scene for performing for using androgen deprivation therapy for prostate cancer. So there are a number of different sources of androgens, the biggest of which is the testes, which produce testosterone. Adrenal glands also produce androgens, and also a small proportion of androgens are produced from the prostate tumor cells themselves. And Prabs talked a bit about how testosterone is converted to DHT, dihydrotestosterone, which binds to androgen receptor, which translocates then into the nucleus, leading to transcription of downstream factors, leading to prostate cancer progression. And the idea of ADT would be to stop it in its path. And it's critical to understand the role of the hypothalamus pituitary gonadal axis in this, and though this took me a little while to understand and get my head around, it really is reasonably simple. So the hypothalamus produces GnRH, gonadotrophin releasing hormone, also known as luteinizing hormone releasing hormone, in a pulsatile fashion, which acts upon the anterior pituitary to produce luteinizing hormone and ACTH. luteinizing hormone acts upon the Leydig cells in the testes, leading to production of the vast majority of testosterone, which acts on the prostate. On the other hand, ACTH acts upon the adrenal cortex, resulting in the formation of adrenal androgens, which also lead to a progression of prostate cancer. But when you have high levels of testosterone, there's a negative feedback control which suppresses further GnRH production and thereby suppresses, reaches a stage where there is testosterone homeostasis. The use of surgical approaches for castration would be orchidectomy, which would remove the testicles and thereby remove 95% of the testosterone that's produced. But other surgical approaches have also been tried previously, though are much more risky, such as hypophytectomy, where you remove the pituitary, or an adrenalectomy, a bilateral adrenalectomy. But these would be associated with a number of other systemic side effects and therefore not routine practice. The gold standard, however, has been the bilateral sub-capsular orchidectomy. This leads to a rapid reduction of testosterone to castrate levels within 24 hours and improvement in patients with symptomatic disease, and their performance status also improves. This can be done both under general anesthetic and spinal, or indeed even under local anesthetic using an inguinal block. It's low cost and simple, and therefore it's used across the world, particularly prior to the advent of GnRH agonists and antagonists. The limitations, however, are that they have a negative psychological impact on the patient, though some of this can be mitigated by the use of a bilateral subcapsular orchidectomy as opposed to a simple orchidectomy. And it's irreversible and also leading to downstream endocrine-mediated side effects. So effective ADT would suppress serum testosterone to castrate levels. It would block the androgen receptor to prevent ligand activation and also lower testosterone activity and thereby suppress downstream transcription of tumorigenic factors. So the goals of androgen deprivation therapy are really to achieve low testosterone activity, and this should be of rapid onset. It should block the testosterone surge, which is seen with some types of ADT, and it should maintain consistent levels of suppression throughout, so that the ups and downs and these fluctuations in testosterone levels do not impact further cancer progression. We aim to minimize side effects. The choice of treatment should be personalized based on clinical features, cost, lifestyle, and culture. The aim in the longer term is to improve patient outcomes with minimizing morbidity and extending longevity. Now, how do you define castrate levels of serum testosterone? So some of the older experiments were done with older assays, and then they suggested that orchidectomy leads to anything below 50 nanograms per deciliter of serum testosterone. But with the advent of newer assays, we found that the castrate levels are indeed a lot lower. Nevertheless, different agencies, different organizations use different thresholds, and conventionally we still use below 50 nanogram per deciliter threshold for serum testosterone. However, more recent data would suggest that lower testosterone levels following castration lead to better outcomes. And here's two sets of data, one from localized and locally advanced prostate cancer, where it was found that time to castrate resistance decreases with an increase in serum testosterone. So the more castrate you are, the less likely you are to progress to castrate-resistant disease, and also the later you are to succumb to prostate cancer. And on the other hand, metastatic prostate cancer, you see a similar effect where lower castrate levels of testosterone lead to a delay in castrate-resistant prostate cancer. So androgen deprivation therapy is driven by either suppressing a GnRH by using an agonist. So instead of a pulsatile fraction, you have a constant supply of GnRH agonists. And this leads to eventual suppression of testosterone production, or using GnRH antagonists, which would inhibit the function of the production of LH and thereby suppress testosterone. An alternative is to use anti-androgens, which would competitively bind against the androgen receptor, or the use of CYP17 inhibitors such as abiraterone, which would suppress adrenal production of testosterone. ADT leads to generally good responses, with more than 90% of patients normalizing their PSA, more than 80% of patients showing an objective tumor response, and also an improved quality of life, though it is palliative with a variable duration effect between patients, and most patients would eventually go on to develop castrate-resistant disease. And a combination of GnRH agonists or antagonists with anti-androgen together is referred to as maximum androgen blockade, which is considered when disease progresses with just a GnRH targeted agent. So GnRH agonists are reversible. They're equivalent in survival outcomes to orchidectomy, and their preparations are available in a number of different dosing frequencies. So the less frequent dosing frequency may mean that patients need to attend less often to their nurses or their medical team for administration of this drug, though it is associated with a testosterone flare in the initial stages, where testosterone levels increase by about 15% in the first 2 days during the first 2 weeks of therapy, and this can lead to some aggravation of clinical features associated with prostate cancer, such as spinal cord compression or bladder outlet obstruction, which can get flared up with this increase in testosterone acutely. This can be suppressed by the use of short courses of anti-androgen, which is typically lasting 2 to 4 weeks. And in comparison to orchidectomy, more contemporary data from the US SEER Medicare database of a large number of patients, which was propensity score matched, suggested the duration that GnRH agonists were associated with an increase in side effects such as development of peripheral arterial disease or cardiac related complications. And the duration of GnRH agonists did impact the risk of adverse events. This really questions the use of medical castration as opposed to surgical castration, especially as in this study, which albeit was a US study, suggested similar costs in orchidectomy and GnRH agonist use, though this may not be replicated in other healthcare systems where there might be other incentives to provide one modality over another. So GnRH antagonists were developed to overcome some of the side effects associated with GnRH agonists, such as the testosterone flare. So drugs such as Degarelix or abarelix did not have that transient increase in testosterone in the first few days as seen with GnRH agonists, and they thereby also led to a rapid symptomatic relief, with sustained testosterone suppression at long-term follow-up with continual use. Though one of the limitations of this is that the injections are a little bit more challenging, so patients, the medical staff need to be trained in administering them, and currently they're only available in monthly dosing frequency, which means that patients need to be seen more frequently by the healthcare provider to be administered this drug. So this is quite a nice summary of GnRH agonists and antagonists, showing the different available options, their routes of administration, how big the needle is, which is a concern to some patients because it can be quite painful, and some patients may need local anesthetic to have these drugs administered. There's variation in dosing frequency, and there's a lot more flexibility with regards to GnRH agonists as opposed to antagonists, which need to be monthly. And interestingly, the injection volume does differ quite significantly between them, whereby Degarelix requires higher volumes of drug to be administered. No wonder some of these patients develop injection site reactions. Interestingly, I also discovered that one of the LHRH agonists are also available in a once-yearly implant, which further makes these quite attractive to minimize the need for regular interaction with medical staff, particularly in a time such as now where we're in the middle of a pandemic. So, lastly, anti-androgens compete with the androgens at the level of the androgen receptor, and thereby they can help prevent the clinical effects of this testosterone flare. when used alone, serum testosterone remains relatively stable with anti-androgens, so you don't get the same side effects of impact on libido, clinical physical performance, or development of osteoporosis, and they offer better bone protections this way than LHRH agonists. Side effects, however, can be quite common, such as gynecomastia and breast pain, particularly with steroidal anti-androgens, where severe cardiovascular complications do lead to reduced use of sapropterin acetate in more sort of contemporary practice. However, non-steroidal anti-androgens are much more preferred, of which bicalutamide seems to be quite well favoured due to a better side effect profile than steroids. These do, however, require monitoring of liver function tests, which can be affected at times. And there are also many new novel non-steroidal anti-androgens, such as enzalutamide, darolutamide, and apalutamide, which have shown some promise in clinical trials in more advanced disease settings at the moment. Though these are more expensive, they are more efficacious in blocking the androgen receptor due to better binding efficiency. Anti-androgens are rarely used as monotherapy because there's reduced overall survival and increased progression as compared to castration. They may be used in combined androgen blockade, though the jury is still out whether combined androgen blockade really does improve survival, as there's meta-analyses showing effects both for and against the use of combined androgen blockade, and this is also associated with an increase in side effects and worse quality of life. So this decision is made on a clinician-by-clinician basis. But things are changing. A recent study regarding oral Relugolix, which is a oral GnRH antagonist, shows some promise. In a phase 3 study, they demonstrated that this oral agent can lead to rapid reduction in testosterone levels, and upon stopping this drug, the testosterone levels can go up again, which is quite useful in those practicing intermittent androgen deprivation therapy. However, this does have some issues. The side effect profile is a bit different. Though you do get reduction in major adverse cardiovascular events, you get an increased frequency of GI-related toxicity and arthralgia. These are early days with these data, and a little time will tell how patients accept these down the line. So there are a number of side effects of ADT, and I won't go into these in too much detail, though I would mention that some of these produce a metabolic type syndrome, and there are ways of mitigating these, such as the use of exercise and perhaps the use of metformin, which is currently being studied in a STAMPEDE trial to assess whether they can suppress the development of these metabolic effects of ADT. One of the most concerning of these is major adverse cardiovascular events, which may occur because of the reduction in testosterone and increase in FSH may make these plaques more vulnerable, which can disrupt and cause coronary ischemic events, in addition to the metabolic syndrome developed due to the other side effects associated with ADT. And there has been a study ongoing called the PRONOUNCE trial, which is randomized to GnRH agonists and with primary outcome measure of major adverse cardiovascular events. This was due to complete in 2020. The recruitment did pause for a period, so it would be interesting to see when these data come out and help guide us in selecting one of these two agents. Other ways of mitigating ADT side effects may be immediate use of immediate versus deferred initiation of ADT when symptoms develop. You do see improved disease-specific survival, but not necessarily overall survival in these patients, so patients need to be counselled quite carefully if they choose to go down this route. And a reason for patients to consider this may be the reduced morbidity and improved quality of life associated with deferring the initiation of ADT. On the other hand, another approach may be intermittent versus continuous ADT. So intermittent ADT would be starting and stopping ADT based upon your PSA levels to allow them to come back up to a preset threshold or the baseline ADT prior to its commencement. It's a bit inconclusive regarding whether it really impacts overall survival, though you may possibly have better quality of life associated with this. And again, patients need good counselling before this is considered. So according to the EAU guidelines, patients with localized disease should really not be offered ADT, irrespective of whether they're receiving radiotherapy or not. But those with locally advanced disease may be offered ADT, particularly if they're undergoing radiotherapy. This can be a shorter course ADT from 4 to 6 months for lower risk disease versus the longer course ADT for 2 to 3 years for patients with higher risk disease. Again, patients who are found to have positive lymph node disease at extended pelvic lymph node dissection at the time of radical prostatectomy may also be offered ADT. On the other patients who are not receiving any treatment to their local treatment to the tumour, but have more aggressive features, may be offered ADT if they meet certain criteria, and this is often a longer course ATD, which may well be lifelong. On the other hand, metastatic disease, the mainstay of treatment is lifelong ADT. Before I come to that, just briefly mention these two landmark studies that really showed that the addition of ADT to radiotherapy did lead to an improved overall survival in the Boller paper from 18 years ago now, and this has since set the standard of care in radiotherapy. And on the other hand, ADT alone is not as good as having ADT plus radiotherapy from this other MRC study. Setting the scene for the routine use of ADT with radiotherapy. On the other hand, with metastatic disease, it really comes down to whether the patient's asymptomatic or symptomatic. If the patient's symptomatic, really they should be started in an ADT, and if there are features of impending spinal cord compression or bladder outlet obstruction, you really should try and avoid the testosterone flare by the use of an LHRH antagonist, such as Degarelix. But if there isn't, you could consider an LHRH agonist in addition to an anti-androgen to prevent the testosterone flare. The immediate ADT could be combined with radiotherapy in low-risk disease, or if the patient's fit for combination treatment with either one of these systemic agents, that could also be considered, and I understand this is something the oncologists on the panel will be talking about in greater detail a bit later. Again, as I mentioned earlier, patients who are particularly well informed and understand the risks of deferring treatment with asymptomatic metastatic disease may wish to do so for preserving their quality of life and reducing morbidity. So in conclusion, ADT is the foundation of the management of advanced prostate cancer. There are a number of different available modalities, which include either surgical or medical castration and anti-androgens, and there's some novel anti-androgens soon coming to the foray as costs lessen and phase 3 results come out in de novo metastatic disease. The optimum ADT strategy balances individual risks, benefits and patient preferences and cultural practices, since the use of medical castration is perhaps a lot commoner in the West than it is in other parts of the world. And there's a lot of variation in efficacy and side effects profiles associated with ADT strategies, which really need to be considered in selecting the appropriate agent for a patient. Thank you very much.